introduction. I'm going to talk to you today about epidural hyperthermia, which on at least 2 levels is somewhat of a hot topic in obstetric anaesthesia. It's also a subject which, as you mentioned, is of particular personal interest. I've spent the best part of the last decade investigating its consequences and also why it occurs. So just a little bit more of a background about myself. I'm a consultant anaesthetist at Imperial College Healthcare NHS Trust, and I work clinically at St Mary's and Charing Cross hospitals. I conduct my research out of the MSK Lab at the new White City campus of Imperial College, and I have a background in human physiology, and my PhD investigated body temperature and obstetric regional anaesthesia. In my spare time, as you can see, I'm a somewhat aspiring triathlete, so I have some experience both as a participant and a researcher with exercise physiology. In terms of my disclosures, I've received funding from the. Let me go back. Sorry. I received funding from the Obstetric Anaesthetist Association and a company called Inspired Ventilation, but I have no other financial disclosures. I must also mention that I'm not an immunologist, so I will have to defer any in-depth questions about immunology. So moving on to the talk. When I talk to obstetric anaesthetists about epidural hyperthermia, it seems that the general consensus is that it's a fairly mild side effect of epidural analgesia for labour. However, having spent some time investigating epidural hyperthermia, I've come to the conclusion that it's not as benign as we would like to believe. With this in mind, I'd like to spend the next 30 minutes or so with you just reviewing what we know about it, about body temperature in the context of epidural analgesia for labour. So I'll start my talk by defining what epidural hyperthermia is. I'll provide a little history about its discovery. I'll then review the literature concerning its incidence and its consequences for both mothers and babies. And following this, I'll examine the 2 proposed mechanisms, the current management options, and I'll finish by outlining some potential future research areas. So to start off with, what do we mean by epidural hyperthermia? Well, keeping it very simple, it's a scenario in which a woman has an epidural for labour analgesia and she develops a temperature greater than 38 degrees Celsius. Importantly, there's nothing in this definition about the cause of the temperature. Another term sometimes used to describe this scenario is epidural-related maternal fever. But in my opinion, this is somewhat of a misnomer. Fever implies that the rise in temperature is caused by inflammation, and as we shall see later, this is yet to be proven. So epidural hyperthermia was first observed in 1989 by Professor at St Mary's Hospital in Paddington. He compared the temperatures of women who received pethidine and epidural analgesia for labour. And he noticed that body temperature did not change in those who selected pethidine, whereas in those who selected epidural analgesia, body temperature increased at approximately 0.15 degrees Celsius per hour from the time of epidural placement onwards. In the subsequent 32 years, there have been 13 trials that have randomised women to the mode of labour analgesia. And so we can now see that epidural analgesia increases the odds of developing intrapartum hypothermia 4-fold. Or in absolute terms, the incidence of hypothermia without an epidural is approximately 5%, whereas with an epidural, it's 20%. Moreover, because these trials randomise the mode of labour analgesia, we can, with a degree of confidence, say that epidural analgesia is a cause of intrapartum hypothermia. Obviously, the other main cause of intrapartum hypothermia is infection, the source of which is most commonly chorioamnionitis. There isn't any evidence that epidurals increase the risk of intrapartum infection, and so for a population such as the UK, where 1/3 of women have an epidural, it's possible to estimate that only half of intrapartum hypothermia is caused by infection, and that the remaining half is caused by epidurals. Established that epidural hypothermia is a common occurrence, the next question should be, so what? Does epidural hypothermia affect either the mother or the baby? Well, unfortunately, it appears that the answer is yes. It's been linked to an increased risk of sepsis evaluation, antibiotic administration, and operative delivery. But for me, the most concerning issue is the hypothesized link with neonatal brain injury. As you can see from this meta-analysis, which looked at the incidence of neonatal brain injury, it's fairly well established that intrapartum hypothermia of any cause increases the risk of adverse neonatal neurological outcome. We also know that in the postpartum period, hypothermia is detrimental to neonates with hypoxic ischemic encephalopathy, and that therapeutic hypothermia improves long-term neurological outcome in such cases. However, and this is a big however, as we've already seen, intrapartum hypothermia has at least two major etiologies, infection and epidural hypothermia. As we shall see later, these two conditions are mechanistically very different, and therefore the association between all-cause intrapartum hypothermia and neonatal brain injury should not be extrapolated to epidural hypothermia. It could be, for example, that the increased risk is only seen in patients with intrapartum infection. And to date, there's only been one study by Greenwell that has directly looked at the relationship between epidural hypothermia and neonatal neurological outcome. In this study of 2,000 women who had intrapartum epidural analgesia, Greenwell recorded the incidences of 4 signs associated with poor neurological outcome: hypotonia, the need for assisted ventilation at birth, poor APGAR scores, and seizures within the first 48 hours of life. And she demonstrated that this dose-response gradient in all 4 parameters with maximum maternal intrapartum temperature. However, 2,000 deliveries is a pretty small sample size for addressing a question such as this, and no data on long-term neurological outcome was collected. Therefore, in my opinion, it's too early to form any conclusions about a potential link between epidural hypothermia and neonatal brain injury. But further research is definitely required in this area. Whilst the link between epidural hypothermia and neonatal brain injury requires further investigation, the links between maternal and neonatal sepsis evaluation and treatment are more well established, as is its association with operative delivery. As you can see from Heeson's 2012 meta-analysis, the risk of both neonatal sepsis evaluation and neonatal antibiotic therapy is approximately 2.5 times greater in those who have epidural analgesia compared to those without. Likewise, the risk of maternal antibiotic therapy is approximately 2.5-fold greater in those who select epidural analgesia. However, these results are unsurprising given the well-recognised difficulties of diagnosing intrapartum sepsis and the potentially disastrous consequences of not. As I'm sure you're aware, the usual markers of sepsis, white blood cells, respiratory rate and heart rate, are all elevated during labour, and so maternal temperature is one of the only reliable markers. As a result, it's routine practice in the UK to investigate and treat both the mother and the neonate if the mother develops temperature greater than 38 degrees Celsius during labour. The final unwanted consequence of epidural hypothermia is an association with labour arrest, which results in a 2-fold increased risk of operative delivery. However, for me, it's not clear if this association signifies a causal link or if it's purely a coincidence. Chorioamnionitis impairs myometrial contractility and increases the risk of labour arrest. It's possible, therefore, that epidural hypothermia has a similar effect on myometrial contractility, but this hypothesis has not been tested. An alternative explanation is that epidural hypothermia and operative delivery is confounded by the duration of labour. Epidural hypothermia is a time-dependent condition, and so women with longer labours are at greater risk of developing it. And by definition, labour arrest also occurs after a prolonged labour. So to summarise, the first part of my talk, epidural hypothermia is common, and in my opinion, it's not a benign condition. So, the next question is, why does epidural hypothermia occur? Unfortunately, at present, the answer is we don't know. There are, however, two potential mechanisms: limitation of heat loss and sterile inflammation. Limitation of heat loss was the original mechanism proposed by Phil Steer in 1989. He proposed that epidurals limit evaporative heat loss, inhibiting sweating. He did not, however, test his hypothesis, and until recently, his original mechanism has received little attention. By contrast, sterile inflammation has received lots of attention over the last 32 years and is, I suspect, the most popular mechanism east of Park Lane. So I'll start by discussing this second potential mechanism. Okay. Inflammatory fever of infectious or non-infectious origin is one of the most common causes of hypothermia. Consequently, approximately 20 years ago, a number of investigators began to research the possibility that epidural hypothermia is caused by maternal inflammation. Before I go into details of these investigations, a quick reminder of what fever is. As shown in the schematic on the left, fever is a state in which the body's temperature set point is increased, normally in order to fight infection. The increase in temperature is mediated by a cascade of pyrogenic cytokines, as shown on the right. Ultimately, the cytokines act on the hypothalamus, which invokes thermoregulatory responses to increase body temperature. Consequently, metabolic rate is increased by shivering or non-shivering thermogenesis, and heat loss is limited by vasoconstriction. As you can see from the cascade, there are a number of markers which can be used to quantify the pyrogenic inflammatory response. But until recently, interleukin-6 is the one that's received the most attention. This is because it's easily recorded in serum samples, unlike TNF-alpha, interleukin-1 and prostaglandin E. Coming back to epidural hypothermia, the first investigations which highlighted the potential link between epidural hypothermia and maternal inflammation are two observational studies from the USA by Goetzel and Riley. Goetzel recorded interleukin-6 at birth from the maternal serum and the umbilical cord, whereas Riley recorded maternal serum interleukin-6 on admission and at delivery. However, importantly, despite their slight mechanistic differences, both studies demonstrated that interleukin-6 was increased when maternal temperature is greater than 38 degrees Celsius. In 2006, Goetzel followed an observational study with an RCT in which women who had opted for epidural analgesia were randomized to receive either methylprednisolone or placebo at 4 hours throughout their labor. Fortunately, the trial was terminated before dose in the high-dose steroid group. Nonetheless, even with the smaller sample size of 200 women, it was demonstrated that high-dose steroids decrease both umbilical cord interleukin-6 and the incidence of maternal hypothermia. Once the link between epidural hypothermia and maternal inflammation was established, the next question was, is the inflammation secondary to infection? It appears that the answer is no. A number of studies, which are displayed in the table, compared the incidence of positive bacterial cultures in women with and without epidural analgesia, and all have concluded that epidural analgesia is not a risk factor for bacterial infection. Additionally, several studies have compared sepsis risk factors, such as the number of vaginal examinations and the duration of membrane rupture, and all have found no increased incidence associated with epidural analgesia. Perhaps, however, the most convincing evidence against infection comes from Sharma's RCT in 2014. in which 400 women were randomized to receive either cefotaxime or placebo prior to epidural replacement. Contrary to the hypothesis, neither the incidence of hypothermia nor, as shown in the figure, the rate of temperature rise was affected by the administration of prophylactic antibiotics. So if the inflammation is not the result of infection, then how do epidurals induce inflammation? As I'm sure you're aware, a collaboration between your own institution and Queen Mary's University has provided a potential explanation. Apologies in advance if I've misunderstood any aspects of this work. This mechanistic study demonstrates that bupivacaine suppresses the physiological increase in monocyte caspase 1 activity associated with labour. It also demonstrates that during labour, bupivacaine reduces interleukin-1 receptor antagonist released from monocytes. As you can see on the left, caspase 1 and interleukin-1 receptor antagonist form part of the physiological pathway that inhibits fever generation, and thus inhibition of fever could result in fever generation. And last year, these results were supplemented by a study from Vienna, which showed that interleukin-6 released from umbilical vein cultures was increased following exposure to another local anaesthetic, bupivacaine. However, as a whole human physiologist, I have an issue with the sterile inflammation theory. As mentioned previously, fever is generated either by an increase in heat production, a reduction in heat loss, or both. However, it's been demonstrated that heat production decreases rather than increases following insertion of a labour epidural. And it's also recognised that following neuraxial blockade, regulation of cutaneous heat loss is impaired due to blockade of vasomotor and pseudomotor tone. So with this in mind, I don't understand how either increased serum interleukin-6 or reduced serum interleukin-1 receptor antagonist titers can lead to an increase in body temperature at a whole human level. So I hope you don't mind if I take a few minutes to consider an alternative hypothesis. As previously mentioned, limitation of heat loss is the original mechanism proposed by Phil Steer in 1989. He hypothesized that epidural analgesia limited heat loss by blocking the sympathetic pathway responsible for the control of sweating. However, he didn't test his hypothesis, and it's received little attention over the subsequent 32 years. I'm biased, of course, but for me it still remains the most plausible potential mechanism, especially when the hypothesis is updated to incorporate the concept of active cutaneous vasodilation, i.e. intrapartum epidural analgesia limits cutaneous heat loss by a blockade of active cutaneous vasodilation and sweating. Now, active cutaneous vasodilation is a relatively new concept, so forgive me for reviewing a little thermoregulatory physiology. As I'm sure you're aware, cutaneous heat loss is regulated by sweating and cutaneous vasomotor tone, and both of these functions are controlled by the sympathetic nervous system. You're also probably aware that sweating is controlled exclusively by the cholinergic pathway of the sympathetic nervous system. You may not, however, be aware that vasomotor tone has dual control from two sympathetic pathways: the noradrenergic pathway, which is responsible for active vasoconstriction, and the cholinergic pathway, which is responsible for active vasodilation. As you can see in the schematic, in a temperate environment and during cold stress, skin blood flow is exclusively regulated by the noradrenergic active vasoconstriction pathway. However, during heat stress, skin blood flow is at least 80% regulated by cholinergic active vasodilation. Now, it's well recognised that heat production is increased during labour, and this study by Eliasson is just one example. Eliasson recorded oxygen consumption before and during labour, and as you can see from the bar chart, during labour, heat production increased by approximately. The importance of this for the hypothesis is that during labour, in order to prevent a rise in body temperature, heat loss must be augmented to match the increase in heat production. It's likely, therefore, that during labour, the cutaneous circulation is actively vasodilated, which is different to all other scenarios in which neuraxial blockade is performed. So what do we know about the effect of neuraxial blockade on heat loss and vasomotor tone? We know from Sessler's work in the 1990s that when conducted from a thermoneutral baseline, which is represented by the green dashed line on the schematic, neuraxial blockade blocks active vasoconstriction, and thus skin blood flow increases and heat loss increases. Additionally, due to the increase in heat loss, body temperature falls. And these recordings have been conducted in a number of scenarios. So we know that this is what occurs in non-pregnant healthy volunteers, non-pregnant patients, and pregnant women undergoing regional anaesthesia for elective cesarean delivery. During labour, however, it's likely that the cutaneous circulation is actively vasodilated, as shown by the red line in the schematic. It's hypothesised, therefore, that labour epidurals block active cutaneous vasodilation, and thus following epidural insertion, skin blood flow and cutaneous heat loss decrease. And there's now some evidence to support this hypothesis. This article demonstrated the principle that epidurals can limit cutaneous heat loss. It showed that when a labour epidural is topped up for an emergency cesarean section, cutaneous heat loss decreases in the expected distribution of sympathetic blockade, and that this reduction in cutaneous heat loss is associated with a rise in maternal body temperature. Obviously, this study doesn't prove conclusively that epidural hypothermia is the consequence of sympathetic blockade, but it does demonstrate that sterile inflammation is not the only potential explanation for a rise in maternal body temperature. I'm sure that future work will determine the primary mechanism, but currently I think it's fair to conclude that the jury is still out. So moving on, what can we do about epidural hypothermia? Well, unfortunately, despite all the aforementioned studies, to date there is no effective intervention. So far, 3 interventions have been tested with RCTs. As I've already mentioned, prophylactic antibiotics are ineffective, and steroids, although effective, induce neonatal bacteremia. In addition, an RCT in 2002 tested the efficacy of prophylactic paracetamol and also found it to be ineffective. Question is therefore, what should we do to mitigate the effects of epidural hypothermia until there's evidence-based intervention can be developed? Well, I've got 3 pragmatic solutions that you might want to consider. Firstly, I think it's worth thinking about labour room temperature. The WHO currently recommends a delivery room temperature of greater than 25 degrees Celsius to prevent neonatal hypothermia. This doesn't mean, however, that labour room temperatures have to be 25 degrees Celsius throughout labour. Perhaps we could consider lowering room temperature to 21 or 22 degrees Celsius early on to minimise the increase in maternal temperature. Another issue is how we consent for labour epidurals. I'd hazard a guess that most of you inform women during the consent process that epidurals makes it more likely they will develop a high temperature during labour. I wonder how many of you qualify this with, and if you do develop a temperature, this may increase the risk of your baby having an adverse outcome. Now, I'm not advocating that you should say that, but I do wonder if this information should be more freely available. Finally, as we still have no method of distinguishing intrapartum sepsis from epidural hypothermia, unfortunately, I think we still have to continue investigating and treating all maternal hypothermia during labour. This will inevitably lead to over-investigation and over-treatment. But personally, I think the side effects of not treating true intrapartum sepsis are sufficient to warrant such a blanket approach. Now, obviously, given all the unknowns surrounding epidural hypothermia, this is a subject with huge research potential. So I thought I would conclude by discussing 3 ongoing studies. The first is a study from Imperial College called Neonatal Outcome and Epidural Hypothermia, or NOAA in short. This is a large retrospective data study looking at the link between intrapartum hypothermia, epidural analgesia, and neonatal brain injury. The key difference between this study and previous work is that it considers epidural hyperthermia as a separate condition to chorioamnionitis. It's just undergone its first interim analysis of 21,000 deliveries, and the results are in line with those described previously. We're currently actively looking for other centres, and I wonder if this is something that UCL might be interested in collaborating on. EpiFever 2 is a follow-on study from the Dell'Arroyo article from Gareth Ackland's group. And it builds on the finding that interleukin-1 receptor antagonist release is inhibited by bupivacaine, and aims to look at why some women may be genetically predisposed to developing epidural hyperthermia. I'm afraid I have little information on study progress, but I suspect that there are those in the audience that may have more information than I do. And finally, in the MSK Lab, we are looking to develop a healthy male volunteer model of epidural hyperthermia to further test the sympathetic blockade hypothesis. We aim to put epidurals into healthy males and to simulate the metabolic demands of pregnancy and labour by getting them to ride an exercise bike. The slide here shows a similar study we have just completed showing the effects of wearing PPE in a simulated hospital environment. The similarity with PPE is that it's also a barrier to cutaneous heat loss. And as you can see from the graph, when wearing PPE, which is denoted by the black dots, your body temperature increases more than when you don't, i.e. it's a heat stress. So in summary, I hope I've convinced you that epidural hyperthermia is a common condition and that it's not benign. I've given you a description of the two potential mechanisms, sterile inflammation and limitation of cutaneous heat loss. I've briefly discussed the lack of evidence-based management strategies, and I've made some pragmatic suggestions for you to consider in the interim. And finally, I described 3 ongoing studies that are looking into the problem. Thank you for listening, and I'll leave you with some photos of my colleagues in the MSK Lab who've been involved in our epidural hyperthermia research.